Okay, so the topic today will be on the secondary use of, or disclosure for secondary purposes of EMR data. And the main focus will be looking at the ability to re-identify individuals from this kind of data and how to de-identify this data so that some of the privacy concerns can be addressed up front. Just a note, everything I'm going to describe to you today has been approved by our Research Ethics Board, just in case you were wondering. Okay, so the basic context is EMRs, electronic medical records. As you already know, they're being increasingly deployed across the country. There are a number of funding initiatives at the federal and the provincial level to accelerate the adoption by family physicians and other specialist clinics, the adoption of EMRs. At the same time, there's growing demand for this kind of data. Demand is coming from researchers. As more data is collected and stored electronically, it's possible to disclose large quantities of data for research. There's a lot of demand for this data from public health. In fact, if you follow what's happening in the U.S., the meaningful use criteria in the U.S., which are the criteria for funding the adoption of EMRs, include an entry or an item related to providing data to public health. So the provision of data for public health purposes is important, it's being recognized, and public health is asking for this data. And of course, you have policy-making purposes as well in government and for commercial purposes. There are a number of commercial entities, of course, who are trying to use this EMR data for secondary purposes. Part of it is for research with the pharmaceutical industry. Part of it is for market research. And you have various health systems, for example, in the U.S., who are creating spin-offs whose sole purpose is to collect data from their hospital networks, clean it up, document it, and resell it. So there are certainly commercial purposes as well. We should not forget the quality issues that come with EMRs. EMR data quality is generally not very high. It's poor quality data. It's not really intended for secondary uses. It's intended for providing care. So it tends to have a lot of quality problems. I will not talk about data quality issues. We'll just assume the quality is good enough for disclosure for secondary purposes. So one way to be able to, for the providers to disclose this information is to obtain individual consent for any of those purposes that I mentioned before. In some cases, it's permitted to disclose data without consent. In other cases, obtaining consent is required. So the first question you ask is whether obtaining consent is practical. And there are a number of reasons why this may be difficult. For example, if it's not practical to go back and ask the patients for their consent to use their data for secondary purposes because there's too many of them. Some of them may have moved, died. It's not possible or expensive and not practical to attempt to recontact all of them. There is no longer a relationship between the provider and the patients. So there may be a number of practical obstacles for obtaining consent in order to disclose the data for these secondary purposes. Even if it is practical, there's an overwhelming amount of evidence that consenters and non-consenters tend to differ in important demographic and socioeconomic characteristics. So there are about 12 variables that we've identified. We did a systematic review of the evidence. There's an overwhelming amount of evidence. This pertains to intervention studies that have interventions like clinical trials, but also applies to observational studies where you're just collecting data or using data that's already been collected. Overwhelming amount of evidence that if you seek consent, whether it's opt-in or opt-out consent, that consenters and non-consenters differ on age, sex, level of education, where they live, rural versus urban, whether they speak the language, income. A number of very important characteristics differentiate consenters and non-consenters, which essentially means that you have a biased sample. If you seek consent, the consenters are going to be a biased subset of the total population that you're going after. In some cases, if those characteristics like age and sex and location and so on are not important for the analysis, then fine, this would not be a problem. But in many cases, these demographics and socioeconomic type variables are important for any analysis. So you should expect some kind of bias if you go down that route. Alternatives to individual consent, of course, are obtaining community, called community consent, where representatives from the community are brought in as part of a committee or an advisory group, and they consent on behalf of the individuals. So in some cases that would make sense, where you're not able to obtain individual consent and the bias introduced by attempting individual consent is unacceptable, then you can try to obtain community consent. And there may be future opportunities to reconsent as well, in the sense that if patients are still coming back to the practice, then you may attempt to reconsent them in future visits. Although, for practical reasons, obtaining consent from patients that come to a clinic for any of these secondary purposes is very difficult, because it's just time consuming and these visits are already quite short. So if any of these consent options are not going to work or not going to be practical, then de-identification provides the basis for waiving the consent requirement. There's no legislative requirement to obtain consent if the data is deemed to be de-identified. So essentially these are the options: obtaining consent or in some form, and dealing with the disadvantages in various ways, or to de-identify the data. Of course, some disclosures are mandatory, and I'll come back to providers' views on providing data. But when it's not mandatory, if it's permitted, discretionary or not, the two options really are consent or de-identification. In some cases, alternative access methods are provided in order to get access to data for these secondary purposes. In most cases, these alternative access methods have been used in the context of research, and these are mainly remote access and on-site access. So with remote access, you put all the data in a secure vault and provide individuals remote access, read-only access to the data through the network. And then the end users would access the information to do their analysis. They'd have all the tools there available to them and so on. So the basic idea is that the providers would give their data to the central repository that's behind a fortress or within a fortress, and then people who want to access that data would access it remotely in a read-only way, so they can't save it or store it or take it out. Or the alternative is that the EMR vendors themselves would do this as well. There are some cases in the US where EMR vendors are providing deep discounts on their EMRs in exchange for the data. As a provider, you get a good deal cost-wise, but the data that's collected in your practice is then made available to the vendor, who would clean it up and resell it, or do analysis on it and resell and sell the reports. For remote access, there's also the option of remote access from specific locations. So the end users cannot access the data from anywhere. They have to go to specific sites in order to access the data. Remote access is vulnerable to simple social engineering attacks. So it's an option. My sense is that it's not a great option. And a simple social engineering attack would look as follows. You get an email from the CIO of your organization with the CIO's signature on it. And this is very easy to do. Saying we've had a breach, a very serious breach that occurred yesterday. Someone broke into our network or hacked into our network and accessed the password file, and all our passwords are compromised. Please click on this link immediately to change your password. And it comes from an authoritative source, and the signature of your CIO or some senior person in the organization. So of course, and this has happened. I mean, I know cases where this has happened. So being a good citizen, corporate citizen, you click on that link immediately, and you go to a website that looks exactly like your organization's website. You enter your password and the new password, you submit, you responded very quickly, and you're very happy. However, what you've just done is give your password away to somebody else, because it's very easy to spoof emails from anybody for that matter, and it's not that difficult to create a website that looks exactly like your organization's website. So, and again, these things have happened. They're very easy to engineer. So these social engineering attacks are simple to do, and they would allow an adversary to get access to the credentials, the passwords, and so on, to break into any system which has remote access. And once they have the credentials, they go in and access all the data. So there's a serious vulnerability from remote access systems. On-site access is another option to access this kind of data. A good example is the Statistics Canada remote research data centers, where all the data is kept, again, in a secure environment, and people have to be physically come in and access that data. This is a very good option. It's quite expensive and requires a lot of time and money to set up and maintain over time, basically, to make it sustainable. So these are the other alternative options to access data for secondary purposes, apart from obtaining consent and then giving the data away to somebody or de-identifying the data. The problem with all of this is that in practice, custodians have been very reluctant to disclose, and I believe this slide is not available in French. I'm sorry, I added this after providing the initial set of slides. But a lot of custodians are reluctant to provide their patients' information for any of these secondary purposes. And I'll give you a few examples. Even when this disclosure is permitted by the privacy laws applicable in that jurisdiction. So in one example is a syndromic surveillance system that's actually set up here in Ottawa and that's been working in Ottawa for some time now, where the 4 hospital emergency departments are providing real-time feeds to Ottawa Public Health. So OPH has been has been able to get real-time information about patients coming into emergency departments across the city with influenza-like illness, for example, or GI syndromes. Has been very effective. However, when this system was being set up, the hospitals were quite reluctant to provide identifiable patient information to OPH for the purpose of the syndromic surveillance system. At the end, we had to figure out a way to de-identify the data to make everybody comfortable with this kind of disclosure. Now, disclosures of data for public health is permitted, and certainly in Ontario, it's very permitted, actually. Ontario is quite permissive in terms of providing data for public health purposes, especially after SARS. However, the hospitals were still quite reluctant to provide identifiable patient information for that purpose. This was going to be without consent because it's not feasible to consent patients when they come to emerge, but they want it to be de-identified. The other example are physicians disclosing data for chronic disease surveillance. So this is another national project. It's collecting data from cities across the country. This is EMR data from physician practices for the purpose of monitoring 5 chronic diseases. And it's the same thing, that the individual practices and the privacy commissioners in the various provinces were reluctant to provide all their data into this national database without a case being made that this is de-identified data. And then the last one is a series of focus groups that we did with family physicians from across the country last year. This was at the peak of the H1N1 epidemic, and so just basically 1 week before the peak during the Family Medicine Forum last year. And the question was, would you provide your patient information for influenza-like illness monitoring to public health? And the general answer was no. They were very reluctant to provide that data. One of the reasons was privacy concerns. They do not want to provide identifiable patient data for public health purposes. And one can argue there's a general public good in providing data for public health purposes, but even under these conditions, there was a reluctance to provide the identifiable information. And in many of these cases, there are other issues as well. For example, the physicians are not getting any benefit or perceive they're not getting benefit back, and this adds to the reluctance. But privacy was certainly an issue in all of these cases. Concerns about physician-patient relationship and what would the patient say if they found out that their physician was providing identifiable data to these outside organizations without consent. So there is a general reluctance. Rightly or wrongly, that's just the way it is. So now let's talk about de-identification. In general, removing names and addresses from a data set does not de-identify it. So if you have a data set, in a lot of cases that I see, the data custodians will remove the names and addresses and then say, well, this is de-identified data, now we can do whatever we want with it. It's quite easy to re-identify individuals from data sets even after you remove the names and addresses and telephone numbers and email addresses and so on, and I'll explain to you how. So one of the reasons for this is here. So this graph that I'll show you is based on data that we collected from Quebec, from about 1 million Montrealers over an 11-year period. This was a project with Miguel, and we got the data from the RAMQ for the purpose of doing this analysis. And at the bottom here, the x-axis is the number of characters in the postal code. So you have from 1 to 6 characters in the postal code, and the y-axis is uniqueness, which is the percentage of the population that is unique. So if you look at the full date of birth, so day, month, and year, and the 6-character postal code, about 97% of the population is unique. Now, I'm comfortable generalizing this to other urban areas across the country. For rural areas, it's not as high, but it's still high. So let's say for urban Canadians, if I have your postal code and your full date of birth, then I essentially know who you are because this is a unique identifier. 97% of the population is unique on that, on those two pieces of information. If we add gender, it goes up slightly, so 97.6% of the population is unique. So what does that mean? It means, for example, if I have the postal code of my neighbor, which I will, they're my neighbor, and their date of birth, and I find a database, any database, and I find a record that matches, chances are that that's my neighbor. I don't need to know anything else for matching purposes. So if I get an EMR database with these two pieces of information, I've basically figured out which record would belong to my neighbor. Now, of course, as you reduce the precision of the postal code, let's say to a 3-character postal code, and the full date of birth, 87% of the population is unique, and so on. You can see, as you reduce the precision, let's say we reduce it to year, the year and the 3-character postal code, a very small percentage are unique, and so on. If we look at adults only as a separate group, it's actually a little bit worse. If you have the 6-character postal code and the full date of birth, then about 99% of the population is unique. So the full date of birth and postal code is a unique identifier for almost all of the population. For youth, it's slightly different. So this is why, even after you remove the names and addresses from a data set, it's still not difficult to re-identify an individual. And explain to you now how I gave you the example of the nosy neighbor, but I'll explain to you now in a moment how you can get this type of demographic information from other public sources. The other thing to keep in mind is, and this is again looking at uniqueness and re-identification risk across the country. So we did an analysis of the census data and built various models. So rather than showing you a series of equations, it's easier just to walk you through an example. So let's say here, if we're collecting age, and let's say there are 90 possible values for age. Let's say we're collecting gender, and there are 2 possible values for gender. And let's say we're collecting race, and there are 5 possible values for race. And at the same time, we're collecting the 3 digits of the postal code. So we have 3 digits of the postal code, age, gender, and race. Just these three pieces of information. And let's look at what percentage of the population in K, in Eastern Ontario, is unique. And here you'll see that around 34% or so of the population will be unique on these 4 variables only. So this is not just limited to the basic demographics of postal code, date of birth, and gender. As you add other pieces of information like race, you already are at 34%. If we add another variable, let's say, I don't know, let's say income, and let's assume there's another 5 possible values for income to this, then essentially most of the population will be at risk of being unique, basically, in Eastern Ontario. So you can start to get a picture of demographic and socioeconomic variables by themselves can make individuals unique, which means that if I have a database, if I see a database which has those values that match what I know about a person, then there's a very high probability that this is the right person that I'm looking for. Okay. So now the other question is, well, how do I get this information? Okay, we talked about the nosy neighbor. So the nosy neighbor will have this kind of background information, or some of it, or a relative, or a coworker, or an ex-spouse. So these are all plausible, but there are other ways to get this kind of information from public sources. So examples of public sources are the obituaries, which are available from newspapers and funeral homes, and there are also obituary aggregator sites that make this simple. And the reason this is relevant, of course, is the case between the CBC and Health Canada, where the adverse drug event database and the alleged ability of the CBC to re-identify individuals in the adverse drug event database who had died by matching with the public available obituaries. So if you have any information about a death, you can use the public obituaries to re-identify these individuals. Then, of course, you have the Private Property Security Registration, the PPSR, which contains information about loans which are secured by some kind of property, for example, cars. So all provinces have PPSR databases. Then you have also Land Registry, which has information on house ownership. And I'll show you now how you can use all of these databases for various things. Other public sources that are also very useful are membership lists, which provide comprehensive listings of professionals, for example, doctors, lawyers, civil servants. Salary disclosure reports, which provide, again, lists of civil servants. You have white pages, you have job sites where people post their CVs. A few years ago, we did an analysis of publicly available CVs, and a lot of people include dates of birth and address information in their publicly posted CVs. Donation sites, for example, Elections Canada maintains sites on or lists of donations to political parties, which includes individual names and addresses. Sports rosters, especially for kids and teenagers, where the very detailed information about the team members is included, their date of birth, their height, their weight, basically all their dimensions, and various other personal information. And of course, Facebook. We've done a number of re-identification attacks on so-called anonymized databases, and Facebook was our best friend, especially for teenagers, again, because they will post a lot of, and young individuals, because they will post a lot of information about themselves. So if we have a medical record with a narrative that describes an incident, chances are, if this individual has an account on Facebook, they also have described the same incident. Let's say a basketball injury or sports injury, or an incident that involves their family or their parents. So by matching these medical records to Facebook, it's not that hard to re-identify individuals. And also, I would like to say something about voter lists, because it comes up quite often. So in a lot of the discussions, especially in the US, people talk about using the voter lists to re-identify individuals. Even in the US, it's not that simple. Many states in the US have restrictions on the use of voter lists for purposes other than elections. So the basic idea is that if you can get a voter list which will include the names and address and date of birth and sometimes race of individuals, then you have all the basic demographics, and then you can use that to re-identify individuals in a database, any kind of database, using those variables. So in the US, the first problem is that there are legal restrictions on the use of voter lists in some states. But the other thing is that about 1/3 of the US adult population, or adult citizens, don't actually register to vote. So the voter list is not a population registry. It only covers about 2/3 of the population. In Canada, it's the same issue. The voter list cannot legally be used for purposes that are outside of an election. However, there are cases of individuals, a recent one a couple of years ago, where a charity that was supporting the Tamil Tigers was found by the RCMP to have obtained Canadian voter lists. So I actually interviewed one of the volunteers who was involved in the election, who was approached by them to get the voter list. This particular individual said no, didn't provide it. But he did say that he was volunteering at an election, and he was approached by this group who wanted him to give them the voter list that he had. So there are cases. It's not legal. If you get caught, you're in trouble. The problem with voter lists, of course, is that the volunteers who participate in these elections, who go around canvassing, did not have to sign a confidentiality agreement when they were given these voter lists, and they do not necessarily have to return those voter lists. So that creates a re-identification risk, of course. I believe there's been some tightening up now at Elections Canada, but I'm not 100% sure what that tightening up is. But I know that they're aware of this, and they were looking at this. Okay. The other way to go around, of course, getting voter lists is to be a candidate in an election. So in Alberta, for a provincial election, it only costs $500, and if of course you're a candidate, you do get voter lists for the riding that you're running in. So it's not expensive. And so this would be another way if you really want to get voter lists. But again, it's still not legal to use them for other purposes. So it's $500 in Alberta, $100 in BC, $100 in New Brunswick. Ontario, it's $100 without any nomination forms. In Quebec, it's free with nominations. So the other important fact, of course, is Canadian voter lists do not contain date of birth. So I know there were attempts to add date of birth to voter lists. From a re-identification risk perspective, that would be very bad because it makes the voter list very useful for re-identification attacks, should anybody get them either illegally or still illegally by being a candidate. There are also other public registries. So I'll just show you a few examples. If we want to re-identify professionals, so the example I will use is doctors. The CPSO maintains this. This is the College of Physicians and Surgeons of Ontario, maintains a list of all the physicians in Ontario on their website. So, and we've done this, and I'll show you some numbers, but basically you would get the list of all the physicians that you're interested in and match that with the PPSR. So the PPSR in Ontario is available on the internet. It costs $8 to do a search, so it does cost money. There's an economic deterrent. And you do a search for each individual name, and when you find a match, you also get their address and their date of birth. So the kind of demographics that would be useful for re-identification attacks. And then you would use the white pages to verify the identity by checking the address and the name against the white pages. So we did that with, actually we did it with physicians and lawyers. We selected a sample from the CPSO and a sample from the Law Society of Upper Canada. But other organizations do this, professional engineers, occupational therapists, physical therapists, and public servants as well through GEDS. So for the CPSO and the lawyers, the ability to get home address was 60% for the CPSO. So we took a 1% sample of about 250 or so individuals from the CPSO. With 60% ability to get home postal codes, or actually full addresses, physicians, about 45% for lawyers. Work address was easy. Date of birth, 40%, 45%. Gender was easy. Even if the gender is not provided, there's some very powerful genderizing software that you can get that's used by marketing companies. If you provide them with a name, they'll make a pretty accurate prediction of what the gender is. And of course, initials. So the hit rate is quite high by taking these membership lists and matching against the PPSR in order to get these basic demographics that can be used for re-identification. And by gender, males are more likely to be it's more likely to be able to get these basic demographics for males than females, and then the kind of demographics that can be used for re-identification. Another example is with homeowners. So again, we did this. Let's say you take a postal code, any postal code, and then go to Canada Post and get a list of all the addresses in that postal code. So now you have a list of addresses. You go to the land registry and get the names of all the homeowners for those addresses. And once you have the list of homeowners, you check against the PPSR to get the dates of birth. So now you have the name, the postal code, and the date of birth, which are the basic demographics that you can use for re-identification. and then again cross-check with the white pages in order to verify those details. So we did this for 2 residential postal codes in Ottawa and Toronto. Date of birth, about 1/3 of the Ottawa addresses, and Toronto's 40%. This attack kind of breaks down for rented properties because the homeowners are not necessarily the people who live there, but in residential areas where the homeowners are the people who live there, it's relatively straightforward. Again, the hit rate is about 1/3 to 1/2. You can get the basic demographics. And for these individuals, of course, for these homeowners, the re-identification risk is high because you have their basic demographics, and you can use that to re-identify them in databases. Civil servants, so you know that GEDS is on the internet, the Government Electronic Directory Services. About last time we checked this, which was about 2 years ago, there were 386,000 odd individuals in GEDS, which covers the whole country. 386,000 individuals work in the federal government. So this is data from StatsCan, and GEDS has approximately 170,000, just under a half of all the names are listed there. So various organizations do not list their employees, of course, CSIS and DND, and individuals can opt out of it as well. But let's say if the name is on GEDS, we did select 40 individuals in health care-related federal departments in Ontario. Actually, they were all employees of the Public Health Agency. And they were all living in Ottawa. So we were able, and we just did the same thing. We had a list of 40 people, checked the PPSR and so on, and we were able to get the home address for half of them, home telephone number for 40%, gender for 100%, and the date of birth for about 1/4 of the individuals. And provincial governments have similar registries as well. So the main point is that by combining information from multiple sources that are available in public registries, it is possible to create these basic profiles of demographic information which can be used for re-identification. And once you know the postal codes, of course, you can link that with the StatsCan data to get the other socioeconomic variables for that particular postal code. So you can construct relatively comprehensive profiles on individuals and potentially use those for re-identification. It's not cheap, it's expensive. The PPSR is not free, so in Ontario it's $8. In other provinces it may be online, it may not be online. When it's not online, there are agents who provide an online service where you fill out forms saying what you want, and they'll send somebody actually down to the ministry and do the search and then send you back the response. So it's generally available across the country. So getting this information is possible. There is an economic deterrent in the sense that it will cost you money to do this for a large number of people, but these are plausible attacks. So I'll give you 2 examples of actual re-identification attacks. There are actually more. There are 13 publicly known re-identification attacks, but two kind of good examples. One is in the U.S. This happened more than 10 years ago. But essentially at the time, the Group Insurance Commission in Massachusetts used to remove all the names and full addresses from the insurance claims. They used to insure all state employees and remove the names and addresses from insurance claims and then make those available. They would sell that data to researchers and policymakers and so on. So one day the governor, who's shown here at the time, William Weld, fell off the stage, went to hospital. Nobody knew what was going on. So an individual went and bought the GIC records, which include all the insurance claims, and obtained the voter list for Cambridge, Massachusetts, where the governor lived, linked the two, and because the date of birth and postal code or zip code and gender are also quite unique in the US, not as high as in Canada, but still quite high. It was possible to re-identify all the claims that belonged to the governor and the governor's family, and at that time it was possible to find out exactly why the governor went, what was the diagnosis when he went to hospital, and so on. So this is a classic re-identification attack where removing names and addresses really did not create a serious impediment to re-identifying the governor's record. Another example here at CHEO, this was a case where so this is where I am based, and we obtained a request from a company for all the prescription records. So this was a commercial entity that wanted to create a pediatric hospital prescription record database, and they approached us and said, here are all the fields we want. This is de-identified data. We've already collected it from 100 hospitals across the country. So please give us that data. So the CPO gave me the database that the company wanted and asked if this is de-identified data or not, as the company was claiming. So I asked people in the office if they knew anybody who was admitted to CHEO during that period. One person put up their hand, said, yes, my neighbor, less than 1-year-old girl. She was admitted in January of that year. And here's her postal code. So we didn't actually have all the details of her date of birth. We knew she was less than 1-year-old. We knew her postal code. We knew her gender. But we also knew when she was admitted, roughly, right? It was January. Anyway, only one record matched. So we found the record. We called the mother up to confirm, yes, it was her. So we knew exactly what she came in for, what her diagnosis was, and so on. Of course, we told the privacy officer, and that arrangement with that data broker had to be completely renegotiated, and they didn't get what they wanted, but we were able to negotiate a properly de-identified data set with them. As for the other 100 hospitals that gave out that data, I'm not sure what to say. But in our case, it was possible to re-identify individuals using that kind of information, which was essentially consisting of postal code information, age or date of birth information, gender, admission and discharge dates. So these re-identification attacks are real. Now, the other question that often comes up is, who would want my data? So what, right? So what if it can be re-identified in theory? Maybe a couple of people have re-identified some databases, but really, what's the risk for me as an individual? So there are a couple of reasons. One is that health information can actually be worth money. So there are people out there who would be interested in getting access to this information. This is an example from Express Scripts. So Express Scripts, which I believe ESI Canada also does the First Nations health insurance claims for Health Canada here, although this incident was in the US. Basically, they had a testing group, software testing group, that was using real claims data for testing. And while perhaps their main databases were protected, the testing group practices were weaker, and it was possible for someone to hack into their testing group and pull down the database. So it's essentially extortion. They got a letter saying, we have all your data, give us X million dollars, or we will expose this. And here, just to show you that we're serious, here's the name of 75 clients, which includes their date of birth, social security numbers, and the prescriptions that we got from your database. So the Express Scripts, of course, called the FBI. They started an investigation and so on. When they said no, then whoever did this contacted these 75 clients and informed them that we have your data and we got it from Express Scripts. So later on, some of these people, of course, were suing Express Scripts for the breach. And then later on, it turns out that the Express Scripts had to notify about 750,000 individuals that there was a breach involving their data. But it's mainly extortion, right? Whoever did this can monetize the data through extortion. Another example happened last year with the Virginia Health Professions Database, where there's a prescription monitoring program where prescriptions for particular types of drugs are documented, and this information is available on a website for specific individuals, like for providers, pharmacists, and so on. So one morning, the front page of the website was defaced with the ransom note down there. I have your bleep in my possession on 8,257,000 patients, and I think the request was for $10 million. So actually, the ransom note was the front page of the website. So whoever did this was able to break in and allegedly get all of the data, or download the data on that many patients, and was extorting the state to return that data or to destroy that data. This is somewhat relevant because there are initiatives in the US to create similar prescription monitoring databases in multiple states right now in the US. So, there are legitimate reasons for creating these databases, but there are clear risks as well, because here you have an example of people's prescription drug information essentially being accessed by a hacker. There are other examples as well, so it's not just extortion. So this example is another extortion example. This is a note, a question that was posted on an underground website for where stolen credit card numbers and so on are exchanged. So I don't know if you can read it, but basically the note was saying, I'm looking for someone that is selling possible database dumps for healthcare or insurance providers. Also completed HCFA 1500 forms will work. In the US, HCFA forms are those that are used by physicians and other providers when submitting bills or claims for reimbursement for Medicare and Medicaid. So actually someone was looking to buy this kind of data, claims data. And the reason is once you have that kind of data, you can make false claims and essentially cash them, like get reimbursements. And then the next one, another posting on one of these underground sites. This person actually had data on 6,561 individuals, claims data on 6,561 individuals. I have a large file that contains 6,561 individual claimed notification report medical records. The file comes with these fields for each person and then kind of listing all the fields here, which include the deductible, the name, the social security number, the diagnosis. And examples of diagnoses are HIV with specific infections, malignant neoplasm, morbid obesity, liver replaced by transplant, and so on. So this was an individual who had obtained a claims database and was trying to sell it. The price wasn't quoted and put there, but there are examples of these things happening where people are selling certainly insurance claims data because it has value, it has monetary value. And then, of course, the other example is identity theft. So this is a public example. This individual, William Ernest Black, was caught in Edmonton more than 10 years ago. What he basically did was he found children who had died in other provinces some years ago and then obtained birth certificates for them. Reissued birth certificates for them, and then used that to create a full identity for these individuals. Because the provinces don't exchange information about deaths, it was possible to go to the province of birth and get a birth certificate when the child had died in a different province, and then created a full set of identity documents, including health insurance card number, health insurance cards, driver's licenses, passports, etc., and was selling them for $37,000 each. And this individual was caught by accident. He was being investigated for something else, and the law enforcement, when they went to his house, they found all these boxes of identity documents, which resulted in them catching him doing this. And then using the identities he created, they were able to, once they discovered this, they found a drug smuggler who had bought one of these identities. He was caught with one of those identities. Another one was an American citizen who was getting unauthorized free medical care in Canada. So they buy this, they come here, get expensive procedures done with those fake identities, and then go back. Procedures they may not be able to afford in the US. So I cannot say how prevalent these things are because it's not known, basically, or at least it's not publicly known. Even law enforcement, if they know, they're not saying how prevalent this is. But there are examples. We know these things happen. So health records have value. They can be monetized. The other side of all this, of course, is public trust. And if the public has a sense that their health information is not being dealt with in a secure and in a secure manner, then they may change their behavior. And there is evidence that the individuals do change their behavior when they have concerns about how their health information will be used and shared, which includes things like not seeking care, seeing multiple providers so no single provider has all the information, lying to their provider, or missing details, or self-medicating and self-treating. And the people most likely to do this are teenagers, individuals at risk of genetic disorders, battered women, people with HIV, so quite vulnerable populations. There are some examples that are public. One quite disturbing one was of women of Dominican origin living in New York who would obtain under the table from pharmacists a drug that was intended to treat ulcers but also induces abortions. So they basically get this and try to induce abortions in alleyways and things like that because they do not want to have a record anywhere showing that they have obtained an abortion. And the main concern there is, of course, privacy. And this was a front-page article in New York Times, I think, a couple of years ago. About between 11 and 13% of Canadians have admitted to, at some point, lying to their doctor or not being totally honest with their provider because of privacy concerns. That's a very large number, of course. And in the U.S., it's higher. It's between 15 and 17% of adults admitting to doing so. So public trust is quite important, and we cannot underestimate the impact of all of these data breach stories and incidents on the public's trust and comfort with the disclosure of their health information for these secondary purposes. And my sense is it's getting worse, of course, because there are more stories of breaches and the level of concern is going up. And it's not just the individuals or the public, it's the providers. So when we did these focus groups last year, one of the things that came up by the providers was, well, we hear all these stories about breaches. How can we trust whatever, X, public health or whatever entity we're giving the data to? How can we trust them to manage the data properly when we hear all these stories about public health units or other kinds of health information custodians losing data? So they're very uncomfortable with that. It is having an effect on people's perceptions. There are other ways, of course, that data can leak. I mean, we hear about data breaches that are inadvertent or deliberate. I'll just go through a few other examples that we found. We found that there's a lot of personal health information on second-hand computers. So we bought a bunch of second-hand computers across the country and looked for PHI, and for about 10% of them we were able to find PHI. One of the worst provinces was actually Ontario. Alberta tended to fare a lot better. All the computers or second-hand drives that we bought from Alberta were wiped clean. And when we interviewed the resellers there, essentially they're scared of their privacy commissioner. So they take this very seriously. Whereas in Ontario, we found a lot of very sensitive data on these machines that were being sold in the second-hand market. And more recently, you may have heard also that on photocopiers and fax machines is the same thing, right? A lot of data is leaking that way. We also found a considerable amount of personal health information leaking through peer-to-peer file sharing networks. We found that mostly from individuals rather than providers, at least in Canada. File sharing networks are used to access videos and music and so on. I'm not going to comment on the legality of this, but also people are sharing their files, their documents from their, say, home computers. In some cases, these are office computers, and some very sensitive PHI is leaking that way as well. We found PowerPoint files on the internet, people giving presentations, and either they talk about their patients directly in their presentations and then they post it after the conference, so maybe they thought it was a closed forum or a small group, and then when the PowerPoint is posted online, the information is available. So we found PHI there, but also people paste, say, Excel files in their PowerPoints, and when you paste an Excel document into your PowerPoint, the Excel document is actually embedded in your PowerPoint, so when you double click on it, all the data, raw data is there. So when people post PowerPoints with embedded objects, in some cases the raw data is there with a lot of identifying information. So you may have an Excel graph with the graph just showing the numbers, but when you look at the Excel file, it'll have more detailed information about the individuals about whom the data has been collected. And then the other thing, of course, is password-protected files. So assuming that individuals, when they send PHI by email, they password protect it or encrypt it in some form, which is another problem because that's not necessarily always the case. We obtained some of those files in the context of clinical trials, which are regulated, so there's even higher level of awareness of this, of leaks and data protection. So these are regulated clinical trials. We obtained 15 files that were emailed in the context of 4 regulated trials in Canada. We're only able to get it for 4 because we had, as you can imagine, strong reluctance for anybody to provide us with those files. But we got 15 files that were encrypted and were sent by email in the context of clinical trials. So we bought a commercial $50 password cracking tool were able to crack the passwords or recover the contents of those files for 13 out of the 15 files. And the main problem was that some of these files were WinZip files, zip files. And the problem is that WinZip, the default encryption on WinZip is very poor. It's easy to crack. It's not even encryption. It's really, very sorry state for to call it an encryption. But very weak encryption, the default in WinZip, even the latest version, version 9. So it's very easy to crack. And so we did a small usability study with a group of people to see whether when they encrypt files using WinZip, they are aware that this is weak encryption, and nobody did. Because the defaults matter. The default is weak encryption, so all the zipped files that we had from those 15 were crackable just because the encryption was poor. The Word documents were similarly easy to crack because they all were Word 2003. The default encryption in Word 2003 is an RC4 algorithm with a 40-bit key, which is also very easy to crack. So these $50 password recovery tools can do that relatively easily. The latest versions of Word, or Office for that matter, are much stronger. The default is much stronger, but 2003 and before, the default encryption was very weak and very easy to recover. So, assuming you encrypt and password protect documents that you send by email, the tools that are used are important. The other thing we discovered, of course, is that the passwords used were lousy. Ottawa 123 was a password. Cobra was a password. Nissan was a password. So these are very poor passwords that are also quite easy to guess. And of course, the problem is a lot of these tools don't enforce any password strengths when you encrypt files. So this has, of course, I think implications on other things in terms of organizational practices about encrypting documents when exchanging them. If you use any of the commonly available tools, you really have to be stringent in enforcing some standards. But also, I think it has implications on breach notification laws because certainly in the US, breach notification laws have an exemption for encrypted documents or encrypted files, but if the encryption is poor or the passwords are lousy, then it really doesn't provide any meaningful protection. So to close then, I think there's a need for doing deidentification and doing it properly, which is more than just removing the names and addresses. If it's done properly, it can be very difficult to determine the identity of the patients in the database. The risk of re-identification can be measured, so you can actually provide guarantees on the amount of risk that you're taking when you're disclosing a particular de-identified data set. And that deals with a lot of the problems that I mentioned in terms of consent problem. If there was a breach and the data was lost, it would be extremely difficult for individuals to determine the identity of the adversaries, to determine the identity of the individuals in the database. Of course, there's the issue of public trust as well, that in general, the public is more comfortable with their data being used for secondary purposes if it's de-identified versus when it's not de-identified. So I think it's very difficult in today's environment to defend not having data that's de-identified when you're disclosing it for secondary purposes. So we've done some work, of course, with various organizations, and examples are Born Ontario, which is the birth registry for Ontario, with ISIS in Toronto for their Cancer Data Link program, where they're disclosing cancer data to linked cancer data to researchers. The CIPSIN project, which is the Chronic Disease Surveillance Initiative, national initiative using EMR data, using at CHEO and Vancouver Coastal Health, so two hospitals. So we're slowly trying to improve the practices across various large health information custodians across the country. And finally, this is contact information. So there's a lot more information on our website on all the things that I just spoken about. I would encourage you to look at the knowledge base as well, because we put a lot of information there and a lot of articles to address the kind of questions that we get. And also have a mailing list on which we send once or twice a month information on material that we've recently posted on the website. And it's all related to anonymity and de-identification of health information. Thank you very much.
Thank you very much.